Okay. Well, I am so happy today to have Anna Arabyan, who is a geriatric pharmacist. She also has a hospice organization, and she teaches pharmacy classes at USC. And with her is her colleague, Kylan, who will also be attending and maybe participating. We're so happy to have you both here today. This is a subject that is of great importance, I think, to everyone, but especially people who are older and who may be facing health challenges. We will let Anna do the first part of the presentation, and then we will have questions. If you have a question, you can use the chat, you can raise your hand, or you can put the little hand up, and I will try to notice and call on you. And let me see, I think most people are muted, which is great. You have the capacity to unmute yourself when it is time for questions, but like to everyone to stay muted now. And Anna, we're ready for you.
Thank you so much, Sally, and everybody for being here. And thank you, Kylan, for helping coordinate all of this and being here for this presentation. So, like Sally mentioned, I come from a background of gerontology, which more of is like a continuum of the aging process. And I also have a degree in pharmacy. And particularly I practice at Generation Care within the scope of operations, but also clinical. I also have a clinical role. Kylan also works with me at Generation Care. She comes from hospitality management, and she's the first person that our patients or clients, families get in touch with. And she is just a superstar at making people feel like, you know what, we got you, whatever it is that you need from us. We're going to help you in every way possible. And I often just say it feels like a really big hug. And many years ago, we strategically removed the word hospice from the name of our organization. And as we go through this presentation, I think you'll really see why, because oftentimes I think the biggest hurdle is that word. And to combat that, many people use palliative care as an alternative to saying hospice to a lot of patients and families. But in fact, it's not actually like an exchange word for word. So we'll go through the presentation and I'll kind of tell you where one begins and the other ends. So we can go to the next slide. Okay. So basically, hospice care is designed for individuals who have a terminal illness. It's the highest level of outpatient care that Medicare provides. And it really is for someone who has a diagnosis that, should the disease take its normal course, would have about a 6-month window. Now, do people outlive that number? Absolutely. A lot of times people do. And so it's all about monitoring and making sure that we're doing our due diligence. And oftentimes what we do is, after like the 6-month mark, we will do regular check-ins by the physician or the nurse practitioner, just to make sure that, is this person still qualified, or did they what we call graduate hospice? Sometimes people do better, especially with certain diagnoses like heart disease, like heart failure and whatnot. When we have a really good way of managing the symptoms of the diuretics and the oxygen, sometimes people live so much longer that we say, you're pretty stable now. And an option would be home health or palliative care. So now let me go into palliative care. Palliative care is an umbrella term that just means symptom management. Okay. And so hospice is actually the highest form of palliative care in the outpatient setting. Now, palliative care, it means symptom management, and it's not necessarily for people who have 6 months of life or less to live. And palliative care is offered in various settings. I'm sure if you guys have heard of palliative care within a hospital, like they call palliative care for consult, just like they would call pulmonology or nephrology. It's a specialty. But it also exists in the outpatient setting at home, which is what we are licensed to provide. And then finally exists in a clinic. So you can go to a palliative care physician. And typically you won't find too much in the community, but if you're part of like a bigger system like UCLA or USC or Cedars, they have palliative care clinics. And people would go there, let's say if they have a diagnosis, whatever their diagnosis is, but they also have symptoms associated. So an easy one would be, let's say somebody has cancer, but it's a cancer that's gonna, they're gonna live with it for years, but they also have symptoms associated with it, or maybe symptoms associated with those medications that they're taking. They could go see their oncologist and then their palliative care clinic. But specifically speaking here, we're talking about, it's a broader approach, and it's really aimed at people who are facing serious illness regardless of the prognosis. So if we have time on the continuum here, hospice is very time dependent. It has to be at a certain point, but palliative care can start pretty much from the time that the person has the diagnosis, regardless of where this time is going. So timing of care. This is exactly what I was talking about. One is dependent on time, which is why the clock is near hospice, and palliative care is less. Okay, so hospice typically starts when the curative treatments are no longer effective. I always tell families a way to know that you're ready for hospice is, are you interested in hospitalization or specialist visits? If the answer is no, I want this person or I want myself to just be comfortable at home or wherever I call home, that could be an assisted living facility, skilled nursing facility, a group home, personal home, apartment, whatever, that's when you know you're ready for hospice. Palliative care is when someone's still nearing curative treatments. If something happens, I still want to call 911. I'm not ready to sign DNR. I'm not ready to say no more. That's when palliative care really can come into the picture. There is a serious illness, but time is not really as much of the essence. Okay, so what are the goals? So hospice primarily focuses on providing comfort, pain management, emotional support, and at the final stages of life. Our goal in hospice is we want people to feel like they're in control. So what that means is at a time when there's really no control, right? Like we're going to one destination. If you want to take this medication, take it. If you don't want to take it, that's okay. It's a lot more emotional, psychosocial. We're there to relieve the symptoms, but we can't stop the process. So with palliative care, it's also aimed at relieving the symptoms and managing the pain. But we're also looking at just overall well-being, and also like overall well-being throughout the course. Because we're not in hospice, if someone says, you know what, they have a swallow precaution, but this person wants to eat whatever thing, we're going to say a risk versus benefit. I'm not too worried about it. Eat whatever you want to eat because that's going to make you happy. In palliative care, we're not so much at the final stages, so we're still taking some of those precautionary measures. That's the best way to think about it. Okay, so where is this care provided? So for hospice, I already kind of mentioned that it's wherever the patient calls home. Typically, it's in their personal homes or in long-term care facilities, or such as assisted livings or skilled nursing facilities. Some people lived in a skilled nursing for extended periods of time. Hospice facilities are more common. You'll find them more often in the East Coast. There's a few sparingly in the West Coast, but they often actually function as a skilled nursing facility that happens to use their beds for hospice, or they function as an assisted living facility that happens to use their beds more for hospice patients. Palliative care can be delivered in various settings. So I already kind of talked about the 3 different ways. The first one is in the hospital when you call palliative care for a consult. The second one is in an outpatient clinic, such as if you were to go to USC, you would go to your oncologist and then you would see your palliative care specialist. And the third one is at home, which is what our team provides. Okay, so what is your eligibility criteria? They're quite different. Again, with hospice, it comes down to terminal diagnosis and prognosis. But the biggest thing is decision to forego curative treatment. And so a lot of what our team works on is the gray zone that comes with, is this curative or is this palliative? Because when you look at Medicare standards, for example, they'll look at blood pressure as curative. I don't see it that way, because if we take down the blood pressure medication, we take it off, that could cause discomfort, right? And so it's about us going through and discussing with the family and the person. We can, even though this is considered curative, we might still see it as something that could cause you side effects if you don't stay on this medication. I just had a talk with a patient's daughter the other day about cholesterol medication. Cholesterol medication has a very long-term effect. When you take it today, you're protecting yourself in the next 2 to 5 years. That's something that we would discontinue because the person has a swallowing difficulty. But let's say something like, she said, well, what about this heart medication? I said, if you discontinue it, you're going to cause discomfort. So that's when we have these discussions of what is truly for comfort, what is truly curative. Now, but the biggest thing is, are you willing, would you just go back to that slide? I'm just going to say a couple of things, Kylan, thank you. The biggest thing is, are you wanting to go to the doctor's office or hospital? If you say no to those two things, or if someone says no to those two things, the family member, we know it's a good time for hospice. If those two things are not said or are not agreed upon, then palliative care comes in, which is saying, you know what, this is alongside your curative treatment. It's not like, they're not mutually exclusive. And that's the difference between hospice and palliative care, curative treatment. So are there any questions until now before I move on, go into this slide, or any clarifications? Okay, I'll keep going. If you have any questions throughout, feel free to write them in the chat. I'll try
There
to.
was a question. I believe I saw a hand up. Was
Oh,
it?
okay.
Yes, Betty. Betty has a question.
Oh, sure. Go ahead, Betty.
Sorry, I was muted. Maybe you explain this, but does Medicare cover palliative care as well as hospice?
That's actually a really good question. And the straight answer is no. Medicare does not cover outpatient palliative care services. There are only certain insurances that do, and California is on the forefront of that. This program was originally started by Kaiser Permanente. Kaiser was the one that did the research, and that would make sense because Kaiser controls their dollars, right? So for Kaiser, whether someone is in home health, hospice, or palliative care, it's coming from the same pool. For Medicare, it's not so much like that. So once Kaiser did the research and they found that people have better mortality, they have better quality of life. It was adopted by certain insurances in California, such as Blue Shield. Blue Shield was the first one. However, the program is underused because it's understood. So there's still a lot of education being done and a lot of research being done, because as of even just a year ago, Blue Shield is like, because we're contracted with Blue Shield, but they don't have palliative care subscribers because it's just a misunderstood program, and they stopped the contracting because they said we have to redo the system. So it's very kind of early stages. Right now, we provide it as on a pro bono basis. And it's usually for people who have been our patient in hospice and graduated, or people that are just not quite ready for hospice. But no, the quick answer is it's not covered by Medicare. Now, what can be covered by Medicare is if someone's on a palliative care program, we can arrange for a mobile physician to come to the house, and then that mobile physician to kind of like be in communication with our team, and that physician will bill Medicare Part B. But that's the same kind of billing that would have happened if one was to go see that physician in their office. Does that make sense?
Yeah, thank you.
Sure, absolutely.
Thank you, Betty.
Okay, so I have a few pointers that we pre-discussed with Sally that I wanted to hit. Maybe what we can do, Sally, is I can go through the presentation as it is, and then I will address each of the kind of like key points that we both thought were important. How does that sound? Just in terms of format. Good? Okay. Okay. So what are the services provided? In hospice, it's honestly a focus on end-of-life care. So we're looking at pain and symptom management number one for us. I'm not as concerned with, like I said, that cholesterol medication. But number one for us is we want people to be painless and we want them to have symptom control. So what are those top common symptoms? Pain, anxiety, shortness of breath, oftentimes constipation related to the medications that are prescribed for pain. And some people have some nausea. Those are the top 5 symptoms we see at the very, very end. And those are the ones where we're really focused on. But throughout that time, let's say somebody has a UTI or they have an upper respiratory tract infection, a URI. Are we going to ignore it? No, because by treating that, we're relieving them from the discomfort. But it's about having that discussion and saying, are you interested in taking this antibiotic? Or would you rather just be on pain medication? Right? And oftentimes this can be kind of like a ethical question of saying, families sometimes will be on the fence about this, especially with people who have conditions where they have a very low quality of life, especially at the very end, like end-stage Alzheimer's. They'll say, should we even treat the next UTI or treat the symptoms of the next UTI? And that's a discussion we have, and we'll give them the pros and cons. But at the very least, regardless of whether or not we're using antibiotics, we're always looking at primarily treating those symptoms. And we always want to say, we'll give you pain control medication, but we'll also give you what we call breakthrough pain control medication. So if your medication that you're already prescribed isn't working very well, here's a breakthrough one. So when you have pain, regardless of the fact that you're taking that, you take that breakthrough medication, you call us and we say, okay, maybe it's time to adjust the dose. A really big part of what these services are emotional and spiritual support. So that really starts with people first making contact with Kylan. Oftentimes I say, she's there. Like I said, it's a hug, and it's about making people feel like, you know what, I'm heard. I know that these people are going to handle this for me. Of course, we have someone who's a counselor on the team. Of course, we have our previous director of nursing was a psychologist. She can come on to the case as necessary, death doulas, but different people, social workers. So we have like 5 disciplines that have nothing to do with medication management. That's how important spiritual and emotional support are for families. And that really bleeds into the bereavement process that continues with us even past when the families are gone. We continue to be in communication with them, and they can always call us for services. Now, really quickly, let me just address the differences with palliative care and those services. Palliative care, I would say we're still doing those things, right? We're still looking at symptom management, psychosocial support, assistance with decision-making, coordination of care, but we're less focused on really symptom management and psychosocial support, namely because just like Betty asked, the funding isn't there for us to really push that. But what is really part of the palliative care process is assistance with decision-making and care coordination. Because at that point, you're faced with a lot of like forks in the road. Do I do this treatment? Do I do that treatment? I used to get my medications from CVS. They're not delivering to me. Do you have a pharmacy? Yes, we have a contracted pharmacy. Even though you're not our hospice patient, we can arrange for them to deliver to you and you don't have to go. So it's a lot of care coordination in that sense, whereas hospice is a lot more hands-on. We're taking care of everything and we're focusing on symptom management. Okay, this goes back to Betty's question, funding for hospice. Hospice is covered by Medicare, and what I want you to know is hospice is an exception program for Medicare, which means typically when one has Medicare, Medicare covers 80% of services if it's straight Medicare. The only way Medicare will cover 100% of services is if you're in a Medicare HMO, also known as Medicare Advantage, which some of you might be familiar with, right? With hospice, regardless of whether someone has signed up for a Medicare HM or Advantage plan, Medicare will pay for 100%. So we never need to bill 20% to that supplemental insurance or out of pocket. There is no out of pocket cost. Medicaid or Medi-Cal in California also pays for hospice. And then finally, private insurances. Private insurances typically, even if you go with a contracted provider, like we had a case this week with a company, an insurance company that we're contracted with, younger person was referred to us, they still had an out-of-pocket cost. That's pretty typical. But with Medicaid and Medicare, there is no out-of-pocket cost. And then also there's the option of private pay. We do accept private pay, but we have to be careful and diligent with accepting private pay because oftentimes people will have like ulterior motives for using a private pay approach. But let's say somebody is from out of the country or their father is here and they're passing and aren't able to go back. Absolutely, you know, we can do private pay for hospice. So palliative care, like I mentioned, is not covered by Medicare. It is in the hospital setting and it is in the clinic setting, but similar to how I described that mobile physician billing Part B, when you go see a palliative care outpatient clinic, like a doctor in their clinic, they're billing Part B just like your primary care physician would. So that's how that billing works. And then the hospital is just part of your hospital stay. But slowly, that's why it says it's often integrated into the standards of healthcare services because it's just part of that group or like part of that package. And there are various funding sources that are starting. There are some grant money, there's some grant money, a lot of grant money in the palliative care world. But overall, there isn't like, we build this for palliative care. This is the code. We're really not there yet. Okay. So the decision-making process. When one starts the process of thinking about hospice, we said that, you know, we're shifting away from curative measures. And so it's often initiated when treatment options are limited. Your doctor will say, you can't keep coming back to the hospital. There really isn't much we can do, right? On the other side, with palliative care, like I said, you're still facing a lot of forks in the road where the decisions are more personal than they are obvious. So I would say that's kind of the biggest difference. Again, I always say like the word hospice is the hurdle. Because I always tell our families, if a train is going to a destination, would you rather be in first class or not? That's the difference. Is the best way to describe it, I would say. That's kind of what those services are. With palliative care, it's, you know, it's almost like you can have it if you want that added support. Okay, next slide. So this is time for some Q&A. That's our phone number and our email address. And
Our QR code is there as well. You can scan it and it'll take you to our website.
Yeah, and there's a frequently asked questions there too that'll answer more of the questions. There's also videos. We have a very educational approach because I come from academia, and Joy, who's our psychologist in RN, she's also one of the deans at West Coast. So there's some, these are just the educational videos that are there where we answer just frequently asked questions. And like Kylan said, yeah, she was so kind enough to make us this QR code, which brought us back, you know, really fresh into this 2023, 2024 era. So I'm gonna just address some of the things that Sally thought that it would be a good idea for us to talk about. And then once I'm finished with those, we'll open it up for general Q&A. So the first one, how is eligibility for hospice determined for people with dementia? The biggest thing we look for dementia is the person starting to become bedbound? Are they consuming less of their meals? Are they recognizing family members? And typically we look at, even though not every dementia patient is Alzheimer's, but we often use that Alzheimer's scale, and we look at if you guys are familiar with the numerations, we look at someone who's a 6 to 7. So that's kind of like where our determination is with Alzheimer's or different dementias such as vascular, mixed, or Parkinsonian. Now, why is this an important question? And I'm glad that Sally asked it. Because with Alzheimer's, it is in its nature a terminal diagnosis. However, with some exceptions, it could be quite a slow and painful process. And so oftentimes this is the diagnosis where we get families wanting to get hospice on board because they've had time to kind of digest the reality, and it might be too soon. And the last thing we want to do is get someone on hospice too soon, use their benefit and then say, oh, it was too soon, we have to discharge you, and they're kind of in that system, right? We want to make sure it's a timely admission to hospice, but there's a lot of guidance before then. Like we'll suggest home health or palliative care. And a lot of times it just comes to really good caregiving, which is another whole can of worms, because especially when the caregiver is a family member, it could be an extremely difficult position to be in. But yeah, that's kind of what we look for dementia. How is pain or agitation handled in palliative care and hospice? So I'll talk about hospice first, and then you'll see the difference with palliative care. Pain and agitation in hospice typically is handled with the medications and what we call a comfort kit. So the comfort kit has what medications to address what we think are the most common symptoms at end of life. That's pain, anxiety, shortness of breath, all of that. I mentioned it to you. So typically what we'll do is we'll do drops of morphine and lorazepam under the tongue for pain and agitation. The reason we do it under the tongue is because there's a lot of vasculature under the tongue, so it has very fast absorption as opposed to a tablet. In palliative care, we're using more tablets. We're not using as many liquids. We're not using as many patches because this person is still going on with their life. And so typically the difference will be the delivery of the medication. Also, we're more concerned with long-term side effects. When someone's at the end of life, are we really concerned with becoming opioid dependent? Not really, because we already have a short amount of time. We could just increase the dose and keep them comfortable. If somebody is going to live with this condition for a long period of time, we might look at alternatives to opioids, which sadly, we don't have many alternatives to opioids. But some people look into cannabis, for example. Some people look into a combination of ibuprofen with Tylenol, which can actually cause a good amount of pain relief. So we look into, breathing techniques and meditations because we want to avoid those opioids as much as possible. Now, if they're necessary, they're necessary. In that case, we give them and we do prescribe them, but we prescribe them in a way where it's more of a tablet format. Okay, the next question is, what is different if a person is eligible for Medi-Cal? So if somebody comes onto hospice and they are Medi-Cal eligible, there isn't that much of a difference in terms of the services we provide. Where there is a difference is if someone has Medicare and Medi-Cal, they have both, then Medicare will pay for the hospice component, but Medi-Cal can pay for their room and board in a skilled nursing facility. So that's the way that someone can get hospice, but also be able to live long-term in a skilled nursing facility, is because they have both insurances. But for people that only have one, which is Medicare, they can only have hospice, or if they do have the ability to be in a skilled nursing facility, it's for a short amount of time.
Anna, we have a question here.
Sure.
If you want to discuss the End of Life Act.
Yeah, absolutely. I'll get to the End of Life Act. What was the question specifically?
It was, would you talk about the right to die options?
Oh, yeah, absolutely. So, the Medical Aid in Dying Act was legalized in California since 2016, and shortly thereafter, we've been in support of it and have walked many patients through the process. So how exactly does that work? Certain diagnoses are exempt. For example, any dementia would be exempt for that because it has to be someone, what we call of sound mind, making that decision. There has to be 2 physicians that agree, and there needs to be 2 consults. And originally the consults had to be 14 days apart. but recently last year, it's the amount of time in between the two consults is now shorter at 48 hours. So it's really important for us to kind of make sure that people get what we call the cocktail as soon as possible. The only insurance that will cover the cost of the cocktail is Medi-Cal, because this is a California law. This is not a federal law. So we cannot use federal dollars to pay for a California legalized medication. The other complication of this is that it takes a lot of, you can imagine, coordination, paperwork, conversations. Sometimes we have difficult cases, right? Like it needs to be ingested orally or rectally. It cannot be an IV, even though that's what people see on TV. It's not an IV. It needs to be self-ingested, and rectal counts. And we have had one case like that, and it was a very difficult case. So you can imagine it's a very involved process. So what we do is we partner with a physician and his group that are the first in California and the best in California, as far as I'm concerned, that provide this service, because they have a whole team of people that specialized in this. And in our case, what we do is we have a patient financial assistance program. So for anybody who needs financial assistance with affording this, we have a pretty robust program. It's up to 4 to 5 times poverty level. So most people would qualify for it unless they have a big income. And they qualify for this group of people to be there and holding their hand through the process. They have a coordinator, they have a social worker. That's in addition to our coordinators and social workers. And the reason we do that is because it's a very specialized need. And it's similar to hospice, but it's not the same. And so that's basically how we have it structured. I think I pretty much, the cocktail changes regularly. There's always researchers, like I went to the last conference in Oregon, they're always changing the amount of liquid, the amount of volume that we're putting into it. It works very well. Tough cases sometimes are involved when there's GI damage, like if somebody has a rectal cancer or a GI cancer, then taking it orally or rectally it could take too long for the drug to disperse, but it's potent enough for it to eventually work. It's just very important that the team that does it is very, very, very specialized, subspecialized, which is why we provide it in that setting. If there's more questions, I'll be happy to address them, but I think I tried to hit most of the most commonly asked when it comes to the Medical Aid in Dying Act. The other thing is, what I'll say is, a lot of people will ask and just feel comforted in the fact that we are able to offer this. But not everybody who asks goes through with it. It's just comforting to know that it's an option. Okay, so I'll go to the other questions. Is there a difference depending on where the patient lives? So if they're at home, the person lives at home, or if they live in a skilled nursing facility, or they live in a boarding care facility. For our purposes, there really is no difference. For us, we provide the same care. If someone needs placement, we definitely help them with placement. We'll have a discussion of whether or not they have that secondary insurance, such as Medi-Cal, to be placed in a skilled nursing facility. Sometimes families, even though they don't have Medi-Cal, they choose for their loved one to be placed in a skilled nursing facility and will pay out of pocket as opposed to an assisted living facility. And that's because they just want a higher level of acuity of care. But what you're getting, the difference is that oftentimes a skilled nursing facility will feel less like of a home than a boarding care or assisted living. So we'll talk about all the different options. We have a lot of contacts all throughout the city, both in smaller boarding care facilities, bigger assisted livings, and they're all priced differently and they're all structured differently, and kind of we'll walk through the process of all the different ones. Barbara said, where is the Right to Die medical team located? So some of them are based in Los Angeles. Some of them are based in San Diego. It's kind of all throughout California. a lot of times the consults will be via Zoom. If there's a family that requests the consult to be in person, we do have providers that are more local in the area. And then oftentimes, if there's a request to have someone there while the ingestion process happens, there's actually a volunteer team that is able to facilitate that and have somebody there. How do you talk to patients and caregivers about hospice? I think honestly, it was really important for me to have someone like Kylan be the first point of contact, because oftentimes I can come in from a more clinical angle, because at the end of the day, I'm a clinician, and she comes in from a more like, this is what you need, this is what we're gonna give to you type of you know, it's a very difficult conversation to have, but it's all about making that conversation almost feel supportive.
Customize.
Yes, yeah, that's
Yes.
I would love Kylan's approach on this specific question.
Yes, you know, one of my biggest things is a lot of our families do not know what Medicare and what the insurance will cover. And so I love to do my due diligence with explaining to the families, this is everything you can get under the insurance. And one thing that we do here is that everyone is different. Every family has different needs, and everyone's going to want different type of treatment. So we don't treat every patient the same. Everyone has a different need, everyone has different requirements. So it's important to really hear from that person and their family what it is that they're wanting in this moment. It's already difficult enough with what they're going through. So I try to take out all of the stress for the family, for the patient, because it's hard enough. So I think being really clear with our care, with what they are going to be receiving and different options that they have for the care, because it's, you know, it's already a trying time. So I try to take all the stress off of the family. They're supported by us and really hear what they want and what their needs are. And, you know, we try our best to make sure we can do everything. Every hospice gets the same, like we say, they get the same bag of tools through Medicare, but really hearing what your family needs and helping out in different ways that we can go around with the system is the most important thing, because every family is different. So we're not all under the same bucket and have the same needs. So I think it's just really important to hear what it is you want and how can we give this to you.
100%. I think a lot of times, like Kylan said, like I think of it like baking a pie. And everybody has those discussions in different ways. But I think just the idea of saying, hey, this is offered to you, you know, why don't you let us kind of support you, is probably the biggest way that we have that discussion is this is offered. And I think that this goes into that last point that Sally had, you know, we wanted to address, which is, yeah, how can we at the Pasadena Village help people who are reluctant for hospice? I think oftentimes when someone's ready for hospice, it's about realizing the reluctance is not going to really change the course. It's about painting the picture of how the course is going to continue, and we want to be as supported as possible. I think support is the key. And also just knowing that this is not some kind of life sentence, you know, like it's not like you sign on to this program and you've given up your rights. You can always discontinue if, you know, if there's a change of heart or a change of mind, stop the program, call 911, go to the hospital. We don't like to see that, because we don't think that it typically 9 times out of 10 has the best outcome. Oftentimes people will just kind of be uncomfortable in the transfer process and in the hospitalization process. But it's all about saying, wherever this ride takes you, we want you to be supported in it.
And you can, like Anna said earlier, you can graduate off of hospice. That's happened before. But I think sometimes with the families, they almost find out about hospice too late, and they say, wow, I wish we would have had this just a few more months before or a few weeks before to kind of make this an easier process. Let me see here. RG, Myers has a question.
Yes, I'm curious about the timing of this, of exercising this right to die and the process and the relationship to dementia. It
Sure.
sounds to me like that once a person has entered whatever, however you determine dementia, whatever the stage that is, and that seems to me like a slippery boundary. But when someone is clearly demented, they no longer have this right. Is the way I'm understanding this, and I'm wondering about expressing preferences like in a DNR in advance, and how does that whole process fit together? How do those
Sure.
things fit together?
Sure. As of right now, just by the virtue of the diagnosis, but just by the nature of the diagnosis, dementia is exempt from being qualified for medical aid in dying because Medical Aid in Dying Act requires for the diagnosis to have 6 months or less of terminal prognosis. And by the time someone with dementia gets to that 6-month mark, they're not able to make their decisions with clear mind. So unfortunately, people with dementia do not qualify. Now, what's an alternative to that? The best alternative that we have realized is that if someone writes before they get to the end stage of dementia, I only want comfort measures. I don't want curative measures anymore. I'm done. Then we can get to the place where we say, and let's say they have a power of attorney for healthcare that makes their decisions. Their power of attorney for healthcare can say, I don't want antibiotics anymore. And naturally, what ends up happening is that upper respiratory tract and urinary tract infections become more and more and more and more. They come more and more often. And so oftentimes families will just say, no more. We're not gonna treat the next one. And when I say oftentimes, it's hard because then the person feels like they're making that call, even though they're the power of healthcare, there's other people involved. But long story short, there is no way a patient with dementia would qualify the way the law is written today, at least not in the United States.
So all you can do is say, do not treat, and then wait for something to happen.
Mm-hmm. Yeah.
So do you have a right to die if you're entering dementia? Or, I mean, is that something that qualifies? So you say, I have to make the decision early before I'm demented?
There's something called VSED, which stands for Voluntary Stopping of Eating and Drinking, which is, I actually went to a conference recently where I met a woman whose mother participated in that when she was diagnosed with dementia, and she felt like she was getting to the point where she was starting to not really enjoy her life, where she basically stopped eating and drinking. And hospice cannot come in until the body is already, because imagine taking somebody that's perfectly healthy and stopping and drinking, eating and drinking. Eventually the body is going to get into the place of your blood pressure is going to change, heart rate's going to change, right? And then hospice can come in and provide those comfort measures. But until the person doesn't basically starve themselves, hospice doesn't come in. Now, it does take a lot of determination, and till date, we've had one person who ended up doing that, and he actually had a spinal condition. But we had to turn away another one who there was absolutely nothing to hold on to, like no diagnosis. If she wanted to, she could have lived for years and years and years. And we go into an ethical concern there where it's very much based on what the team is comfortable with. But that's the only viable option in the United States.
I might mention this does not solve the problem, but the organization Compassion and Choices, which was instrumental in getting the Death with Dignity law in California, does have a dementia advanced directive form now that you can get on their website and fill it out. It really says kind of what Anna's already said, is that you can then opt to not have any treatment. And I don't know, I don't have examples of whether that's been successfully used for people. But it's something that Compassion and Choices as an organization is quite aware of and concerned about.
Mm-hmm. Yeah. Thank you for sharing that, Sally. That's true. We have seen it used but I think where this is really important is that sometimes an advanced directive, it's really difficult to say on the advanced directive, never give me antibiotics. You know what I mean? Because you might be very far from terminal and need an antibiotic, and then all of a sudden the person is still able to make their decisions. But I've seen that definitely done at the very end of life, and it's very important to have a power of attorney of healthcare who's very on board with honoring your wishes and the advanced directive and really understands what that means. And it's important to have those conversations very clearly early on.
One
Would
of the
something like
things- oh,
would it
sorry,
make
Dick.
would it make sense to have something like an interview, recorded interview, to specify your wishes for an advanced directive, bringing in someone who had special training in this, similar to like the kind of knowledge that you have? Is that something that might be a technique in providing support for exercising an advanced directive?
Absolutely. I think maybe involving a fiduciary can be where that would be a great practice, because basically you're having a third party who doesn't have that emotional tie to you, who really understands what you want, who you have it written with. And you can even have an attorney or notary there where you're making these decisions, so that the decisions are made solely with exactly what you would have wanted, and you're not risking other people's interpretations of it as much.
Well, what I'm thinking of is that someone like yourself, for example, who would understand what the requirements are, would be able to ask specific questions in the interview where you could express your preferences on specific questions that would be relevant in the decision-making process. That's more what I'm thinking of than the fiduciary, than the decision-making. It's preparing the advanced directive in such a way that it's clear that the conditions or the requirements for exercising this have been met in advance and are on record. That's more where I'm thinking about it.
So like Sally said, I think the closest thing to that would be the team at Compassion and Choices. They specifically specialize in compassion and choices. Like that's literally it. And they have people all over, in California, Arizona. I mean, they're everywhere. And this is literally their specialty, where people will find us through them. And so that's also the organization that I said has volunteers that they send to sit with people if they want and don't have anyone to be with them when they actually take the cocktail. So it's a wonderful organization. And I would think going through them and filling out the advanced directive as clearly as possible, and then possibly even getting a third party to be the power of attorney of healthcare and not somebody related, or maybe somebody related that you really trust will honor the advanced directive, I would say is the best combination of ways to go.
I had one more small question, and that is what, when someone goes on hospice, what services are actually provided? Like how often would a nurse come? Would there be a hospital bed, etc.?
No, thank you for bringing that up, Sally. So when someone gets on hospice, there are different disciplines involved in the care. And this goes back to like how I said, there's Medicare standard and then how everybody bakes the pie a little differently. So I'll kind of tell you how we tell our patients when they come on and our families in the explanation of benefit process, which is what Kylan does. So typically we have nurses, bath aides, spiritual counselor, social worker, volunteers as needed, but oftentimes we use either students as volunteers, or now we're having a death doula program as volunteers, or if we need a volunteer, we can we have a relationship with Compassion and Choices, so volunteers. We have physicians on the team, nurse practitioners. I'm the pharmacist on the team. And then we contract out should we need anything else, like whether it's podiatry, some people have mobile dentistry and things like that. So that's kind of like the core.
Wound care.
Yeah, wound care is another one, wound care specialists. So as for the frequency of how often people get these services, usually it's about 2 times a week for nursing, 2 times a week for bathing, and then all the other services are ancillary. So they're on basically like, depending on the need, we have it with different schedules. And I think what's really important that people don't realize with hospice is a lot of families think, oh, these people are going to come and they're going to stay. But that's not really what happens. We come, we do the visit, we make sure everything is okay. We train the caregiver, if the caregiver is family or is a paid caregiver, and then we go. We are on call 24/7. We're available 24/7, but we're not available, you know, to be at the house unless it's the very end of life or unless it's a crisis. Then we have a higher level of care called critical care or crisis care or continuous care, where nurses there 8 to 12-hour periods at a time until either the person passes or the crisis is averted. But yeah, that's a really big distinction. And then in terms of the frequency, sometimes, let's say if someone has a very complicated wound case, they might have at the last week a nurse going every day, but that needs to be justified and documented. So it's very much, I'm very wary to tell anybody the frequency, because the frequency is based on the severity and the need. Yeah, I hope that answers the question.
We have a question from Betty.
Hi.
Sure.
My brother died last Saturday, and he was under hospice care in Boston.
Mhm.
And one thing that was fascinating to me was they sent in a musician. And apparently this guy, a young guitarist, works full time for hospice and goes around and plays music to patients that are dying and to their families. It was amazing.
Mm-hmm. Yeah, we used to actually have one of our volunteers was a ukulele player. And she would go and play the ukulele. So this goes back to like different people baking the pie differently and prioritizing various needs. I think, you know, I see a lot of really cool programs happening. And, you know, some people will say, there's pet therapy, there's music therapy, there's a lot of different add-on services. And it's just important to see what's a good match for you. And I'm so glad your brother had that, because honestly, a lot of times at the end of life, music is like, I guess it's the memory that brings emotion.
Yeah.
It inevitably does. It's kind of like, and oftentimes our spiritual counselor, she will go and ask them what music they like and just play it with them, even if the person is nonverbal, because the memory of the music just does things where there's actually videos and studies online where people will start talking or singing even though they haven't been verbal for many, many years. Yeah.
In line with what you were saying, there were several fascinating things. One was the only way that his kids could get him out of the hospital and back to assisted living, where his wife was to say he wanted to be on hospice. Now, the daughter was a nurse who had worked for hospice, so maybe she knew that trick, because he wasn't actually being diagnosed with a terminal illness. But when he got back to the apartment, he died within a couple weeks. So he probably was terminally ill, but they didn't quite know that there was such a diagnosis at the time. But that was their trick to get him back into assisted living. And then the other thing was, there were so many people coming in and out that we visitors were completely confused who was who. But hospice was coming in and out. But on top of that, they had 24/7 private care coming in and out, plus the assisted living team coming in and out.
Oh, wow. He was one lucky guy. He basically had every,
And meanwhile, he was unconscious the whole time. So
yeah.
it was pretty frantic, but it was very, very interesting experience, and I learned a lot.
Uh-huh. So the private caregiving was probably arranged by the family. That's out of pocket. The hospice was there. That's true. With assisted living, they are mandated to call 911 anytime that the patient has any kind of like fall or something they can't manage medically. But hospice is the only exception to that. So families will say, they've put them on hospice. You can't call 911. You call.
Oh, maybe that's what they were doing. Yeah.
That's
So he
exactly.
kept falling. Yeah.
Yes. Yes. And then as far as not having a diagnosis, that's something that is very much an ongoing problem now, because there used to be a diagnosis called failure to thrive. And Medicare removed that diagnosis because it was abused. But oftentimes we're looking at the person and there's no like diagnosis when it comes to an organ system.
Yeah.
It's just failure to thrive or old age, or it could be a million different things. And unfortunately, that diagnosis was removed due to misuse, which puts us kind of in a pickle, and we start running all through all the different records trying to just find a diagnosis.
And we have RJ has his hand up.
The
RG, sorry.
yeah, the question about the music, there's a lot of work going on in neuroscience and the impact of music on the brain. And I recently saw a presentation about dementia, and they were talking about the impact that it has. And they mentioned a program like what you were talking about, having a musician come by at end of life, and it really made a lot of difference. The other question I had is you mentioned about coverage of the cost of hospice. And I think you said that Medi-Cal would pay for it, but that Medicare didn't. But what about Medicare and private insurance supplement? Is that something that I would need to talk to my insurance company about and see if my policy covers cost of something like hospice care?
Hospice care is covered both fully by Medicare or Medi-Cal. They both cover it fully. So
Oh,
you
I
do
thought you
not.
said it didn't cover something.
No, this is the only program for which your supplemental doesn't matter. So even if somebody doesn't have a supplemental, it's covered 100%.
Okay.
Anna, can you discuss the pulse form?
Sure. So the PULSE form stands for Physician Order for Life-Sustaining Treatment. And it's basically like I guess you could say like a quick and dirty, almost like a very guideline for us to know what the person's wishes are. So it goes in 3 parts. The first part is, do you want resuscitation or do you want DNR, which is do not resuscitate? And so typically we always say, if you're going to be on hospice, the goal is to be on do not resuscitate, because even if we do CPR, most people need to go on a ventilator, and we can't put you on a ventilator in the house. You're going to the hospital anyways. So just by virtue of wanting to not go to the hospital, it's like, you would naturally choose do not resuscitate. The second part is, do you want any, which goes to the next part, which is, do you want any breathing help? That goes to the ventilation. And again, that's not something we can do in hospice, so the person would have to be hospitalized. And the third part is talking about parenteral feedings. So any kind of artificial nutrition should the person not be able to eat. Now we do have clients, people who are on hospice who have a long-standing G-tube. And depending on diagnosis, they could be on that for a very long time. That's not as much true with the ventilator. And finally, on that same form, it asks if there is an advance directive, because even though this is kind of like the quick and dirty, it's not a full advance directive. And so that can also be indicated on the form, and then it's signed either by the person themselves or their medical power of attorney.
Doesn't it also have to be signed by a physician?
Yes, after the family signs it, it's signed by the physician, which goes back to the title of Physician Order for Life-Sustaining Treatment. Yeah.
And Claire has a question.
So my opinion about PULSE is that it's appropriate for people living with terminal diagnoses.
Mhm.
Many people think that everyone should have a pulse on their refrigerator. And I argue that if you're still a living person,
Mhm.
you don't know whether if you fall down in your dining room, you're going to want an ambulance to take you to the hospital
Mhm.
or not. And so putting something on your refrigerator that says, under no circumstances do I want to go to the hospital, is, in my opinion, premature.
Mhm.
If I have a heart attack, I do not want to be resuscitated. That's not necessarily premature, but I'm interested in when you think a pulse is an appropriate thing. And I think what I'm hearing is once a person is on hospice, a pulse becomes irrelevant.
No, it actually
Oh,
becomes
okay.
very relevant. I would say it's the most relevant. In fact, when someone comes on hospice and they have a previous pulse, we redo a pulse unless it's within like the last couple weeks to a month. Because you're right. For example, I have an advanced directive, but I don't have a pulse because thankfully I don't have a terminal condition at this time. But in my advanced directive, it says that if, for example, it gets to the point where I'm going to be kept alive with artificial nutrition and really have no quality of life, then I would not like to be kept alive. I think that's fair, but I'm in agreement with you is pulse is for someone who not necessarily is in hospice, but has a terminal condition that has a condition that could become very terminal very quickly or is terminal already. I believe that it would be very appropriate at that time. Now, an advanced directive, unfortunately, most people don't really think of an advanced directive, early is, and honestly, I've been working in hospice for many years and I'm now in my mid-30s and I finally have one, but for a long time I didn't because it's just something that you put off and you think you don't have to worry about. But I think an advanced directive is a wonderful, wonderful tool.
It sounds to me like that the advanced directive is the key, that you have to be very careful about how you put it together and the kinds of questions that you have to address and specify in the advanced directive. Is that correct?
Yes, it's pretty detailed. The advanced directive is pretty detailed. And I think with it, along with it, you can assign a power of attorney for healthcare. And so, for example, going through the process, it was really interesting to me who I chose because it wasn't the person that's necessarily my emergency contact, but it's the person that I know will black and white just do what it says there.
Yeah. Well, I
That
have all
is
of
the
those. The
most
questions.
important thing
Yeah.
about an advanced directive is that you talk to the person you name to take care of you when you are no longer able to do so, and you make sure they understand what your wishes are.
And that they have the legal power to make the call with all the rules that surround the whole process. That's what I'm concerned. Like, how do I know? I have all of those documents, and how do I know that they're going to work the way I want them to?
Yeah, I think you have a lot of fear around whether or not they're going to be honored. I think having a discussion with the team at Compassion and Choices could really help. Possibly talking to a fiduciary can really help. I think, is it ever going to be 100%? I think like right now we have, someone whose daughter is their power of healthcare attorney, but whose wife is the one living with him. And so we have to really kind of be very careful with how we honor the wishes of his advance directive, the power of attorney's wants, and the person living with him. I think it's very valid, your concern. But at the same time, I think having the discussions and looking at the advance directive will also make you realize that, yes, it's a concern, but there are definitely steps you can take to make it less of an issue.
And I think also just if you wanted to kind of get started with speaking with your family on this process, you could also do the 5 wishes form. If the pulse is, we're not there for the pulse, there's always the 5 wishes
Mm-hmm.
where you can.
What's the 5 wishes form?
So the 5 wishes form is I know the 5 wishes.
Mm-hmm. Yeah, it's a little pamphlet. It's a nice little start to what you would want. And
Yes.
it's not like a full advance directive you get notarized or get from your attorney, but it's essentially just that. It's your 5 wishes, and it asks you specifically, what do you want in this case and what do you want in that case? Like for my mom, she did a 5 wishes form first, filled it out halfway through, and then that was like a really good segue for me to say, okay, now everybody's going to get an advance directive, but even if you don't have one, it's a good kind of launching pad.
Yes, it can
Where
start
do you get that form?
You can even Google it, you'll find it online.
Yeah, you know what? I'll put a link in the chat here, but it's just a great way to start the conversation with you, with your family. You can sit down and kind of just discuss, what is it that I want? And
Mhm.
so those 5 wishes, the first one is the person I want to make care decisions for me when I can't. The second wish is the kind of medical treatment I want or don't want. The third wish is how comfortable I want to be. The fourth wish is how I want people to treat me. And the 5th wish is what I want my loved ones to know. So it's just a first starter piece to kind of get your mind, the gears turning on what it is you want, how you want to be treated, and discussing that with your family, just to start that conversation. It's a hard conversation, but it's an easy segue to kind of just get out there what you really want.
I want to say a little something about advanced directives and the post. One thing that is important about them to me is that as long as I am conscious and have my mental facilities, I can change them in the moment. For instance, if I have a post that says do not resuscitate, et cetera, and I have something, a fall or some injury that I am perfectly conscious, I can say in that moment, disregard this form. This is what I want now.
Mm-hmm. Mm-hmm. Thank you for bringing that up, Sally. Yes.
And my late husband had a friend who had a heart condition, and he had a post on his refrigerator, and he, with DNR and everything, and he had a fall and was conscious, and he said, take me to the hospital. I want treatment for this.
Yeah. We often tell our families, this is a guide, it's not set in stone.
Right.
Just like signing up for hospice, I think Claire said it's important to note that if a cure comes along, the patient or situation changes, they can come off hospice. Yeah, it's not set in stone. I think we come back to this topic that I said in the beginning is like, as much as it's possible to give the person control of their situation. We're here to help. We're not here to determine the course. And yeah, thank you for bringing that up. That's true.
So are there any other questions? Well, I really want to thank both Kylan and Anna. I think they have done a really comprehensive, wonderful job of explaining these things, and really appreciate that you wanted to do this for the village.
Thank you, thank you, thank you.
Thank you. Thank you so much, for having us. Thank you, Sally, for being so patient with us, Kylan for helping coordinate, and just, being here to kind of say it from your perspective, because at the end of the day, it really is a team, and everybody comes in it with their background and their knowledge, and this level of care would not be possible with one person. It would not be possible with 2 or 3 people. The number of people that are behind us and everything we're saying is immeasurable. So Thank you for the time, and
Thank you for having us. And I know if you have any questions after this Zoom, please feel free to give us a call. I'm always on, or send an email. I'll be happy to answer any questions.
Great. Thank you.
thank you so much.
Thank you.
Bye.
Have a
Bye-bye.
great day. Bye-bye.